ग्राउंड मोबाइल खराब है
भाई कुटना मत मुझे वन वन इधर के 1 से 2 पे आएंगे नहीं
क्या हो गया बच्ची को?
हे बंद केलंय काय ग?
हो थांबा, आवाज करू नका, 1 मिनिट थांबा.
basically what we are facing in today's world is that the young cardiologists and maybe the extremely experienced cardiologists
लास्ट वाला हमने जो दिया था 17/12 को 17 का हो गया 2 तारीख को हमारा
मैम पिलिसे క్వశ్చన్ చేస్తుంది కరెక్షన్ చెప్తుంది మేము రెండు సార్లు రాసి కూడా ఉన్నాయి స్టార్టింగ్ లో ఫస్ట్ 1 month లో నేనైతే
Okay, good afternoon. I will just share my screen in a moment.
झालं सुरू नको का काय करू
Hi, Sandeep.
Hi. Happy New Year to you all. Well, we welcome you on behalf of the state chapter of the Maharashtra State NNF. Sunil, are you there?
Thank you very much. Thank you very much, and Happy New Year to you too.
Yes, sir. I'm here. Yes, sir. Yes, sir.
Yeah. So, would you like to introduce Professor Somsekhar Nimbalkar?
Definitely, sir. My pleasure.
Yeah.
Thank you, Sandeep, sir. And as sir said, again, welcome everyone on behalf of State NNM chapter again for one more interesting, practical, and very important talk. Nobody can miss it, and it must to know talk. And as sir said, we wish from Maharashtra State NNM everybody uh, very happy, safe, and healthy 2021 most probably. Let's see how it turns out.
I think we need to tell everyone to unmute or to mute themselves. We don't want any disturbance, please. Ghansham, can you mute everybody other than the speaker?
Yes, sir. I'm behind it. I'm behind it.
Yeah. So Sunil. Sunil? Sunil, are you around?
हाँ
So, Sunil, shall we start? Somshekhar, you are around?
Yeah, I'm there.
Yeah. So we welcome you on behalf of the state chapter of the NNM. We all have a healthy and safe 2021. Dr. Somshekhar Nimbalkar, we all know he doesn't need any introduction. I think Sunil probably stuck somewhere.
Sir, yes, there. Yes, there. I'm here, sir. I'm here.
Yeah. So please introduce.
Sorry so much, Shekhar, sir. A lot of disturbance here, but again, we'll try like it is like somehow it becomes smooth. Everyone, please mute yourself. Everyone, please mute yourself. Everyone, please mute yourself. Yeah, thank you.
Shall I start?
1 minute, Somshekhar, 1 minute. I think Sunil is having some problem with his connectivity.
The problem is like I'm getting like Ghanesham sir is muting everyone, so I am also getting mute sometimes. So
Your
okay.
co-host.
Sir, Somshekhar sir, better to start rather than this like thing. I think.
Okay, but introduce Professor Nimbalkar before he starts.
Sir, so like lucky to have sir here. Sir is a professor and head of Department of Neonatology and dean at Paramsukh Medical College, and he's a national code of IAP NRP. And from this introduction itself, you know that this is a very close chapter. Is very this is talk is very close to his heart, and sir has done a lot of research also on this part. We're lucky to have here, sir. Over to you. Please start.
Thank you, Dr. Gawan and Dr. Sandeep Kadam and all office bearers of Maharashtra NNF for inviting me. While most of us have access to the latest journals and these articles are freely available, so I would definitely go through all the changes that are there. But I prefer if I have more questions across during the presentation rather than it being a monologue. I don't mind answering questions in between the presentation. If you look at the guidelines per se in 2020, not much has changed, to put it very simply. And 2015, a lot of changes compared to 2010 or 2020. On the request of Dr. Gawane, I have even looked at pointing out some changes that happened in 2015 too. We will go through the algorithm and something called as the class of recommendations and level of evidence. We look at what major concepts that were changed in 2015 were reaffirmed, and anticipation of resuscitation need, umbilical cord management, temperature at birth, and so on and so forth. So we'll cover all these issues over the next few, maybe 20 or 30 minutes. Okay, we should know.
ये कर रहे हो क्या boss? Record कर रहे हो?
We should know that. So we should know that we had been looking at neural resuscitation for many years. People have been resuscitating newborns for 60, 70 years, but somewhere around in 1980 or so, a group of experts in US got together and decided to form kind of a resuscitation algorithm about how to go about resuscitating neonates. So they had a book, an neonatal education book or something like that. It was not called as neonatal resuscitation program as you know of it now. But this education book was instituted and people started following that. If some of the earliest people who did that are seen in the picture. Dr. Vidyasagar came to India with one of the drafts of the program from US, and I think in 84 or 85 did one of the first NRP programs in India before it was even officially launched in the US. So India has close connections with neonatal resuscitation, including some of the research that has happened in the last 20-25 years. While initially the resuscitation program was based on expertise and what people felt or what should be correct, over a period of years it started becoming based on evidence. So there is something called as the International Liaison Committee on Resuscitation, which looks at all resuscitation, not just neonatal resuscitation, but even adult resuscitation and pediatric resuscitation. Now, what ILCOR does is, for a great many years, it used to change recommendations every 5 years. Somewhere around 2-3 years back, somewhere in 2016, 2017, they decided to have a continuous updation of science. But despite that, every 5 years they have continued to release what has changed in the last 5 years as a recommendation in major journals. So most of the changes that happen in neonatal resuscitation guidelines get published in pediatrics as well as in Circulation Journal, which is the main journal of American Heart Association. These are all freely accessible, at least from 2005 onwards for the last 15-20 years, and you can get all those articles online. So if you want to know what has changed every 5 years, it might be a good exercise to read those articles, which have been published since 2000 or so. Now, resuscitation science changes every 5 years, and there is a method to the change. What happens is, ILCOR was first founded in 1992, and they had one of the first international advisory statements published in 1997. And in 1999 was one of the first ones when they published a statement related to newly born infant at around that point of time. And then there was an updated guideline in 2000, 2005, 2010, and 2014. So this is how neonatal resuscitation guidelines have progressed. And we had the most recent guidelines recently, a few months back in 2020. Now, how does the ILCO process work? Every nation or every major region has a resuscitation council. So there's a nation resuscitation council, there's a European resuscitation council, there's a Canadian council, there is an American council. So in America, the AHA looks after, the American Heart Association looks after resuscitation. And so all of these councils have members who are part of this various resuscitation teams for pediatrics, adults, etc. And these members keep on changing every few years. So there is a committee which looks at somewhere at like in 2020-21, they would decide a list of questions that they would assess over the next few years. Now, these questions are then broken down into teams, and various teams are given the responsibility of answering those particular questions. So the questions that were answered in 2020 and formulated into guidelines for the changes that were published in 2020 were different from what were asked in 2015. So we'll come to that a bit later. So basically, we have progressed from a concept of just experience-based neonatal resuscitation to more and more evidence-based neonatal resuscitation. If you look at the 2020 guidelines, and as I said earlier, not much has changed, but what has actually changed from 2015 to 2020 is a lot of evidence that was assessed or seen in 2015 got what do you say, refined, or there was more evidence to support the changes that happened in 2015. Even if you go back to the 6th and 7th edition, that is the 2011 and 2016 edition of the book, you can see few chapters have changed. One of the few things what was changed is there was positive pressure ventilation, chest compressions, and endotracheal intubation, and endotracheal intubation went up in the chapters. This is from the book. So things have changed. The next edition, that is the 8th edition, we will see in the next few months. I believe that in the AAP conference in I think Chicago that was held this year, that book was particularly discussed or released. So we'll have that in print format in a few months from now. In 2016, these are the major changes that you see on the screen. Umbilical cord management, delayed cord clamping was defined. Again, normal temperature of the newborn in the delivery room was not specified earlier, but began to be specified later on. And again, interventions to maintain normal temperature for the preterm were clearly defined. And so, and also the use of warm humidified resuscitation gases was introduced as part of the guidelines. And for babies who are unintentionally hypothermic babies, there was no particular focus in the 2015 guidelines either on rapid or slow rewarming. So both could be done. And maintaining normothermia in resource limited settings, they had approved, and they had looked at ensuring that skin to skin contact or kangaroo mother care should be given. In fact, this particular reference, one of the references for this particular guideline is some research work that we had done in Karamsad and published in 2014. So clearing the airway when meconium is present was one of the major guideline changes that happened in 2015. Again, this was based on three research work that was done in India. I think it was done in Vellore, Pondicherry, Pondicherry and in Delhi. And in this one, the Pondicherry one was a reference, but close soon after, the one in Delhi was also a reference. So this change that has been brought about in the 2015 guidelines actually came from research that was published from within India. Another major change that happened in 2015 and was not particularly relevant to us was the 3-lead ECG was required by the AHA to be used in neonatal resuscitation. Now, when we say required, it means it said that for assessing newborn resuscitation, heart rate in newborn resuscitation, providers should use ECG. Now, why is that important? One is because once it becomes a recommendation by AHA or the committee, then hospital administrators across the US would be forced or would be required to buy this particular ECGs for monitoring heart rate. And while it may not be so relevant in India because of resource constraint, it is something that people would need to aspire to. Again, as you see, administration of oxygen in preterm infants, it says about 21 to 30% that changed. And usage of saturation monitor came in 2010. And in IAP and NNF, we have been asking people to buy saturation monitors that can be used in newborns in the delivery room. So there are two things that are being enforced, or which is preferred that should be used in delivery rooms. One is the blender, so that you can provide titrated oxygen to the premature baby in the delivery room, and second is the saturation monitor, saturation monitor which can find out rapid changes in saturation in the newborn, not the ones which are available for 2,000 rupees in COVID patients. So good saturation monitors which have fast averaging times should be utilized in the delivery room. And so these two things I would think and is recommended by IAP and NF both, that most delivery rooms should preferably have. Again, positive pressure ventilation changed quite a bit in terms of how it is evaluated during the resuscitation in 2015. And also, if you're doing chest compressions and PPV together, then you would evaluate at the end of 60 seconds. So these changes were significant in 2015. Induced therapeutic hypothermia was recommended even in resource limited settings. In 2010, it was not recommended, and in 2015 they recommended it. Now with the HELIX trial results being presented in New York in December, again there'll be a question mark whether we should be using therapeutic hypothermia in resource limited settings. So that is still open for debate, but we'll not go into that. Guidelines for withholding resuscitation changed quite a bit, and they have again changed in 2020. So we'll look at that later. And there's something which has been a point of discussion for education of NRP. It is well known that you tend to forget whatever is taught in NRP program in 3 to 6 months time if you're not using it regularly. So residents are unlikely to forget, but consultants, if they're not participating in resuscitation, are very likely to forget resuscitation steps. And so it was discussed but not confirmed that maybe every 6 months people should get trained in resuscitation. So there are new concepts for resuscitation which are called as low dose high frequency simulations, where you practice skills on a weekly basis even if you don't have deliveries, especially in low delivery settings. So these are other methods which can be used but which are not kind of recommended at that point of time. Since we are already 20 minutes late, I will just skip the slides which were part of the initial presentation. One thing is because newborn resuscitation, when it is taught, the neonatal mortality may not drop so much because of improvement in resuscitation, but the stillborn mortality drops. What happens is babies who are born and die within maybe 15 minutes, half an hour, 1 hour, especially in peripheral hospitals and other settings, are recorded as stillborn so as to reduce the paperwork which is there. So whenever neonatal resuscitation training is done across districts or states in large geographical settings, it is noted that the stillborn rate drops, but the neonatal mortality may not drop that much. Okay, so but still it is seen, it is recommended that we continue to train because we expect birth asphyxia related issues to drop considerably. Again, if you look at neonatal mortality in the first 2 days of life, then birth asphyxia is one of the leading causes. Whether training in neonatal resuscitation improves mortality, a study in 2017 suggested that, again, as I said earlier, stillbirths reduce considerably, and the 7-day neonatal mortality drops by 47%, and the 28-day neonatal mortality drops by 50%. So that there is definitely need to do training for neonatal mortality. Almost 85% of newborns require only simple newborn care, and around 15% will need stimulation. And then 7% of the approximately 50% who require stimulation will require bag mask ventilation, and less than 1% will require advanced care. So, the reason for knowing this is the way we train for neonatal resuscitation generally is divided into what is called as basic newborn resuscitation and advanced newborn resuscitation. Basic newborn resuscitation generally stops at training people for bag and mask ventilation, and it does not extend training of skills to chest compression and further. That is reserved for what are called as advanced care providers. So generally pediatricians or neonatologists, or maybe some experienced or good NICU nurses. But in general, people who are just present at deliveries and who are not extensively involved in neonatal resuscitation should know to do bag and mask ventilation. Advanced care providers should be available close by, but most people should know bag and mask ventilation, and that's how those skills are divided. If you look at programs across the world, in India, it is called as Navjat Shishu Suraksha Karyagram, and there's a new one which has been launched on November 21st or so last year. And in US or in African states or in other states, it is called as Helping Babies Breathe program. So again, where basic newborn resuscitation is taught. So the skills for resuscitation, the ones which are important are actually preparation for birth, managing the baby at around the time of birth, initial steps, and bag and mask ventilation. So these are the most important steps for understanding and learning. And unless these are learned very well, then if these are learned very well, then you may not require the further steps. But if you don't do these steps correctly, you are likely to go into chest compressions and intubation, etc., which again increases the chances of decreases the chances of survival for the babies. Okay, so this is the 2015 update, and this is the 2020 update. If you can look at both these algorithms, you could actually, unless I had written that it is a new one, you would think that it is the same one, because it is actually the same. So the algorithm has actually not changed from 2015 to 2020. That also means that the training probably that we do for neural resuscitation will not really change much. One of the things that changed in 2015 was most of the training, at least in the US or advanced countries, went onto the phone. So what was called as ENRP, or using the phone or mobile apps to learn resuscitation, became the norm rather than in-person training. While we have not moved to a app that is being found, it is likely that over the next year we might move to a app-based or a web-based neural resuscitation program. The NSSK also is actually currently web-based, and there are two web-based NSSK algorithms that are available, which have been used in Himachal Pradesh and another state, I think Rajasthan. But from what feedback I have got, they're not very user friendly, because you need a computer and a laptop to utilize that. Since most of us access everything through the phones, it is better to have an app-based neural resuscitation program rather than something which requires a computer. So as I said earlier, though the algorithm is the same, we have more evidence available and more research available. At this point, I want to state that there are two things that happen when research is related to neural resuscitation is published. One is actually the changes are published, and then there is a consensus of treatment. That means the other article tells you why the changes have happened. And much of the language that is used while writing this particular manuscripts has to be very careful. And in the next slides, we'll see how that language might change. Now, if you look at this, there is the class of recommendations and the level of evidence. So these are there in the literature that is published. You can look up the original articles for more details. But I wanted to bring it to your notice that there is something as the class of recommendations. So either the recommendation is strong, moderate, or weak, or it may show no changes, or something again it is strong, but you should not do it. Kind of, it can cause harm. And the level of evidence depends upon various articles, various kinds of studies that back that particular recommendation. Okay, so the writing group tells you what is the recommendation, and level of evidence is based on the quality of scientific evidence. So as I said, class 1 is strong, class 2 is moderate recommendation, class 2B is weak recommendation, and class 3 is no benefit, and it is kind of like a experience-based recommendation. And class 3 is harm, which is strong recommendation for the risk which outweighs the benefits. And if you look at the level of levels of evidence in the blue thing that you see, again, level A is from high quality evidence from more than one randomized clinical trial or RCT, meta-analysis, or high quality RCTs. Also, we should understand that anything which is an RCT does not automatically mean that it is high quality evidence. You can actually get very poor quality evidence from a badly conducted RCT, and you might get better evidence from a non-RCT study if it is well conducted. So just equating a randomized control trial to good quality evidence is not a very good idea while understanding science of levels of evidence. Okay, and so that's level A. Level BR is derives from moderate quality evidence from one or more RCTs, and level B non-randomized from various other kinds of studies. So basically, depending on what kinds of studies are used, these levels of recommendation, levels of evidence are made. So I think I've made my point about what these two things mean. And this class of recommendations and levels of evidence is there with every neonatal, update that comes. If you look at the 2005 update also, in that paper also they have mentioned what is the class of recommendation and what is the level of evidence. And these levels have kept on changing depending upon how the science of generating evidence has changed over the last 2 decades. Okay, so now next go to what has changed or what was reaffirmed. So guidelines apply mainly to the newly born baby who is transitioning from a fluid filled womb to the air-filled room, and you can consider that even for during when it is stabilized in the delivery area, or you can even apply it in the rest of the neonatal period also. Okay. Again, it reaffirms that lung inflation and ventilation is important, and it is important to maintain cardiovascular and temperature stability, as well as, and this is more important and it has been more stressed upon, on the promotion of mother-infant bonding and breastfeeding, recognizing that healthy babies transition naturally. 2 or 3 decades back, baby, when it was delivered, the cord was cut and the baby was kept away from the mother and was monitored. So that is no longer the normal thing to do. The normal thing to do is, after the baby is delivered, either vaginally or through cesarean, place the baby in skin-to-skin contact. And that is what should be done. So that is something which has been reaffirmed. If it is still not being done, and it is challenging and people move slowly, but it's something which we need to continue to kind of press for. Trained persons, identifying risk factors, and team training are very important. More evidence has been generated, and again, this has been reaffirmed. Delayed cord clamping, which was suggested in 2015 or recommended in 2015, continues to be recommended, and also includes for preterms. Again, healthy babies to be managed skin to skin with their mothers. Radiant warmers and other warming adjuncts for babies who are preterm or low birth weight. Again, that was what I mentioned in 2015. And assessment for heart rate by auscultation or by palpation, and oximetry and electrocardiography or ECG are important adjuncts. So again, they are reaffirming what was changed in 2015. Okay. Again, PPV ventilation is important. A lot of things were expected on oxygen therapy when this guideline was brought about, but not much has changed as far as oxygen therapy for preterm babies. Again, we have gone from 21 to 30% for preterm babies, and oximetry should be used to target the natural range of oxygen saturation that occurs in term babies. We do not have curves for preterm babies as yet. 3:1 in chest compression ratio. Now this is exclusively for neonates, because if you look at the children who are bigger, then you have the pediatric chest compression to inflation ratio, which kind of takes over. But in neonates, even if the baby is intubated, then you need to have coordinated chest compressions to ventilations. Again, vascular access, IV access is preferred. I will skip this because most would change. What changed a little bit was, unlike earlier where they said that if there is 10 minutes of asystole after a good resuscitation, you can discontinue ventilation. In this particular change, they have mentioned that you can continue resuscitating for a little bit longer. This is based on studies which showed that neonates who were resuscitated for maybe 30 or 40 minutes had good outcomes. So based on that, they have changed this slightly, where they said up to 20 minutes of resuscitation should have been done before discontinuation. So in terms of timing, it has gone from 10 minutes to 20 minutes. While the earlier 20 minutes said 10 minutes of asystole, now it just says 20 minutes of resuscitation. So basically, they would want us to resuscitate a little bit more than what we have been resuscitating so far. And one of the most important things that has changed in neural resuscitation is training in terms of teams. Preferably, people should be getting trained together as teams. There should be briefing and debriefing. So I will discuss each of these things in detail. So as I said earlier, anticipation of resuscitation needs. So at every delivery, one person should be there, and you should have a standardized checklist and a standardized risk factor assessment. If you don't have a standardized risk factor assessment, then you oftentimes get surprises, and you should have been prepared for that if you had asked for it. Okay, so training, preparation, and teamwork is important. In areas where there are less deliveries, then it is preferable that every week the team gets together and does a drill or does a simulation to ensure that everybody knows what is being done. But in settings where there are large number of deliveries happening, this may not really be important. So if you don't anticipate, then there can be delay in assisting the newborn, and that can increase the chance of death. And up to half the babies require PPV. Who require PPV may not be identified if you have not looked at the risks before the delivery has happened. And again, a list of various supplies, etc., need to be there. Now, how to go about that is, in the delivery area, it is better to have a list of supplies that are kind of pasted, and you can check with the supplies if all the things are there when you're trying to when you're going to resuscitate a baby. Because in areas where people keep on changing, such as colleges or hospitals where residents work, then when a set of residents changes, it might be difficult to train or ensure that everyone is of the same level. And having more number of checklists is a very good way of ensuring that people follow the guidelines. Okay, so this I've discussed earlier. Umbilical cord management, again, delayed cord clamping for 30 seconds. This timing has not changed. And if you look at the bottommost one in BR or 3 no benefit, for less than 28 weeks, definitely cord milking is not supposed to be done. So delayed cord clamping is definitely good, and it reduces the need for blood pressure support and transfusion and may improve survival in preterm babies. And of course, cord milking should be avoided. You can consider early cord clamping when placental transfusion is unlikely to occur, such as maternal hemorrhage or hemodynamic instability, placental abrasion or placenta previa. So it's not that you have to wait for 30 seconds, but if there are other issues such as on the maternal side, then you can consider clamping the cord early. Temperature at birth, admission temperature should routinely be recorded because it is an independent risk factor for mortality when the baby comes to the NICU. So it's something, anything less than 37 degrees 36 degrees can be, and increases the chance of mortality. There is an association between hyperthermia and increased morbidity and mortality in very preterm and very low birth weight neonates. So sometimes in the zeal to ensure that preterm babies do not become cold, you might end up making them more warm, and that also is something which is problematic. So if you look at between hypothermia, normothermia, and hyperthermia is pretty problematic, and we should try and avoid it. Okay. Temperature management for newly born infants has been put out in detail. All healthy babies should be skin to skin, and it is seen that if you ensure that there is skin to skin care, then temperature remains normal for a longer period of time. There is reduced mortality, there is improved breastfeeding, there is shortened length of stay, and there is improved weight gain. In the study that we did in Karamsad, I think in 2011-2012, we as a part of the study, we ensured that babies got as much skin to skin care on the first day, not only during the delivery, but we actually did it after the delivery. After 30 minutes after the delivery, we gave them skin to skin care for as much time as we wanted, starting around 30 minutes after delivery. And on the first day, we got at around 16 to 17 hours of skin to skin care on an average, and our rate of hypothermia in the postnatal room in babies who are more than 1.8 kg dropped by 800%, by 8 times. So we had just 4 hypothermia episodes in the babies who were skin to skin versus 32 who were not on skin to skin care. So in the point, what I wanted to make is skin to skin care is very useful, and it's something which should be utilized regularly. This does not only mean delivering the baby on the mother's abdomen, but keeping the baby there for as far as the current recommendation goes, for at least 1 hour. And if it is at least 2 hours, then there are better more chances of there are more benefits to keeping it for 2 hours. Okay. Using plastic coverings can reduce the incidence of hypothermia, but they were not directly compared to uninterrupted skin to skin care. So we also have used plastic coverings, and we have published for transport, etc. And it shows that even covering the babies in plastic, babies between 32 to 36 weeks of gestation, does improve management of temperature. So as you can see on the picture on the left hand side of the slide, there are many ways to manage temperature of the newborn: exothermic mattresses, plastic bags of wraps, woolen caps. Okay, you can use bundles of various strategies. Okay, and so these are using Ziploc or the food grade plastic bag. So we have used Ziploc for our babies, and it ensures that the baby maintains a temperature in that plastic. Okay. You can do all the resuscitation level resuscitation procedures even when you keep the baby in the plastic bag. Now, clearing the airway and tactile stimulation for newborn infants. As I remember, during when we were residents and we started doing neonatal resuscitation, we were very excited to do suction of the nose and the oral cavity, so that there is nothing is aspirated. That's what we used to do many decades back. And but that is something which is frowned upon completely, totally now. It is not necessary to do routine suctioning of babies who are breathing well or crying and are being cared skin to skin care with the mother. So you don't require to do routine tactile stimulation or suctioning, even if the amniotic fluid is meconium stained. So this is what is there. And avoiding unnecessary suctioning helps prevent risk of induced bradycardia. So I remember as a resident when we used to do suctioning, baby used to suddenly, because somebody used to be monitoring the heart rate, and we used to find that the heart rate definitely drops pretty fast sometimes for no reason. And as I look back, I know that we must have been doing vagal stimulation for babies who are actually normal. Okay, so there is no benefit from routine suctioning after birth. So this is something which we all need to know. Now, coming to tactile stimulation, if there is ineffective breathing effort or apnea after birth, then tactile stimulation may stimulate breathing, and we do not need to do flicking of the soles, which has been banned even in the 2015 edition. But we should try and keep just rubbing the back and maybe the soles, just rubbing and not flicking the soles. If after initial assessment there is visible fluid obstructing the airway or concerned about obstructed breathing, then the mouth and nose may be suctioned. So only when you think that there is a block, then there might be necessary to do it. Otherwise, you don't need to do it. Okay. So only if you're thinking of airway obstruction. There is probably some research going on whether that they might be doing repeated tactile stimulation in preterm babies might be beneficial, but it is still not yet put out as a recommendation. Endotracheal suctioning for apparent airway obstruction with meconium stained amniotic fluid is no longer recommended for non-vigorous infants. For vigorous infants, it was not recommended a long time back, so that has not changed much. But only if you're looking at what do you say, airway obstruction which has happened, then you might want to go ahead and do it. Otherwise, you don't need to do it. Okay. So the three RCTs that I mentioned here, I think all three are from India, or definitely two are from India. Okay. If you look at the assessment of heart rate during neonatal resuscitation, as I said earlier, it is preferable to have auscultation of the precordium rather than looking at the umbilical cord. So we have been looking at palpating the umbilical cord and giving the heart rate, but that has changed, and we need to look at auscultation of the precordium. You can use pulse oximetry and ECG, but remember, pulse oximetry takes at least around 60 seconds to 1.5 minutes before you get good heart rate on the pulse ox. So during that time, you would definitely need to look at other things. And the most common thing would probably be auscultation of the precordium, because ECG is what most people would not be using. Though it is supposed to be the most rapid and accurate measurement of the baby's heart rate. So yeah, and I discussed this already. Underestimation of heart rate can lead to potentially unnecessary intervention. So this is something which we need to be careful about. So the reason of accuracy of heart rate is many times if it is a busy area and there is a lot of noise, it can be sometimes difficult to get an idea of what is happening. And if you underestimate, then you can cause a lot of unnecessary interventions. And if there is overestimation, you might delay the interventions. So using ECG does not mean you stop using pulse oximetry, because that you're using for a different reason, for administration of oxygen. Given the evidence of ECG during initial steps, it is suggested that definitely ECG should be used in providing chest compressions. Again, whether we can use it in India, I don't know, I doubt, but it is a recommendation. If somebody can manage it, people should be using it. And if the ECG heart rate is greater than 60 minutes, a palpable pulse or audible heart rate definitely rules out what is called as pulseless electrical activity. If you look at ventilatory support after birth, PPV and CPAP have been recommended for a long period of time, and CPAP got a boost maybe about 10 years back, and it has more and more evidence to suggest that we can go ahead with CPAP for very small babies. So newborns who do not breathe within the first 60 seconds after birth or are persistently bradycardic, need to require PPV at the rate of 40 to 60 per minute. Now, the most important part of neonatal resuscitation, and which should drive the actions of everyone in the delivery room, is that they have to ensure that the baby, by 1 minute of life, if the baby is not breathing or if the heart rate is less than 60, then the baby should be get the first breath from your bag and mask ventilation or your TPs or whatever. And so one of the way in which you can use quality improvement measures for improving your delivery room interventions is checking by what time after birth did a baby who was not breathing got the first breath from a resuscitation device. There are newer devices which are available, which you might want to look at. And every second delay that you delay the ventilator support increase the risk of infant death. And how do you assess whether the ventilation that you're doing is correct or not? The most important is actually an increase in heart rate and less reliability chest expansion. And I think everyone should keep in mind that having a lot of chest expansion because you are very enthusiastic may actually damage lungs of definitely small babies and even bigger babies. And it has been seen, and there are studies published where if you give 6 large big breaths to a newborn pup, then you can have release of inflammatory parameters throughout the body, which can cause secondary damage in faraway organs. So hence it is important to ensure that you don't do very vigorous ventilation, but just enough to ensure that there is a rise in heart rate. And so you have peak inflation pressures, which we often don't measure, but it is possible to have manometers and look at what pressures you are delivering. And generally, what we use is 5 centimeters of water when we use the TPs, but we do not know exactly whether 5 is better or 4 is better or 6 is better. There may be potential harm in providing sustained inflations for more than 10 seconds. So using sustained inflation is of no use. That has been already proven by a large RCT. And so we are looking at potential benefit of sustained inflation between 1 to 10 seconds is now currently uncertain. CPAP is again recommended more in this particular guideline, that it is helpful for preterm infants with breathing difficulty after birth or after resuscitation, and may reduce the risk of bronchopulmonary dysplasia as compared to endotracheal intubation, endotracheal ventilation in very preterm infants. So one of the things that probably we need to improve in our resuscitation is the usage of CPAP in the delivery rooms. And this does not mean you give CPAP with 100% oxygen, because you're going to be causing damage with 100% oxygen. So having a blender in the delivery room is one of the most significant investments that you can make in the delivery room, so that you can use it for providing CPAP. Okay. Oxygen administration, we have discussed there was not much difference between high or low oxygen concentrations. The general consensus is start off between 21 to 30% for preterm babies. Initiation of chest compression in newborn babies, if the heart rate is less than 60 per minute, is based on expert opinion. And so we do not have any studies to say less than 50 or less than 70. So the number of 60 is just based on what has been then going on for ages based on expert opinion, and we don't have any particular study to prove it. So you could look at having a study for 50 or 70, but that's beside the point. Again, when you start chest compressions along with endotracheal, along with bag and mask ventilation, the current guideline is to go to put the oxygen to 100%, but we do not know whether it is still useful, whether 100% is useful or 50% is useful. So once you have return of spontaneous circulation, that is the baby's heart continues to breathe and baby has possibly even started breathing on its own, then you can so once you start resuscitating and the baby's heart rate comes back to more than 100, then you can think of dialing down the oxygen concentration based on the saturation. So this is something which you can look at. There are various methods. Earlier we would have seen that there were various methods of providing chest compression, but in the 2015 guideline, the 2-thumb encircling hand technique was preferred. And again, in this one also it is preferred. And it can be used either from the side of the infant or from the head of the newborn. If you look at the 2015 2016 AAP book. It shows the pictures which you can see, and it is useful and it can be done in delivery situations. IV access, preferably you would want to have umbilical venous catheterization, so that has not changed. And outside the delivery room, you can use the intraosseous route if umbilical venous access is not available. So suppose the baby is 8 days old, 10 days old, and you don't have, then you can use the intraosseous access. Volume replacement, you can use uncross matched type O Rh negative blood, and you can use 10 ml per kg over the next 5 to 10 minutes. Post-resuscitation care has not much changed. We have discussed about hypothermia and how to manage it. I'll skip this. You can use either rapid or slow rewarming. We discussed with withholding or discontinuing resuscitation. So whether you start resuscitation or you start, whether you don't start resuscitation, both are supposed to be equal ethically. It wouldn't change much. Okay, so it's the same. It's also important to understand that if you start resuscitation, in what babies you are going to start resuscitation. So there is the decision to whether to start or continue depends upon is individualized, and you can probably stop after 20 minutes after birth. So this is what I want to clarify. The ethics of whether to continue or not to continue or when to start resuscitation in very small babies is covered in a paper that we wrote in, I think, 2020 beginning or 2020 in Indian Pediatrics, and it is freely available. Variables that may be considered, that whether there is availability of advanced neonatal care, specific circumstances before delivery, and wishes expressed by the family. So there are ways in which this decision can be taken, and having more discussions is pretty much important. Okay, I will skip this. I have discussed this earlier, 3 to 12 months, and historically repeat training has occurred every 2 years, but there have been moves that people should do it every 6 months or so, but we do not know, because making people get trained every 6 months is a huge logistical nightmare if there are large number of pediatricians. Okay, short practice training I discussed. Briefing or debriefing. So briefing is the discussion about an event that is yet to happen, and to prepare all those who are involved, and therefore reduce the risk of failure or harm. So when you go to delivery, when you discuss what are the risk factors, what is the baby like, what is the expected weight of the baby, do the Doppler show anything? So all that would be considered briefing. And debriefing is after the event has happened, after you have finished the delivery and the baby has been either admitted to the NICU or the baby is with the mother. Then you can look at it as discussion of actions and thoughts after an event, to ensure that there is reflective learning. Now, adult learning depends upon discussing it and thinking about something that has happened, and that leads to your better learning. So this is something which we need to do it for every delivery that happens. Often happens in colleges. So when a baby is delivered and baby is admitted to the NICU, then people who went to the delivery are asked what happened, what was there. So they discuss. So this debriefing kind of happens on the next day during rounds. But having a debriefing immediately after the event is probably better, because everything is fresh in everyone's mind. Okay, and so these have been recommended since 2010, and I expect that things will improve even further in the next guideline in 2025. Okay, but we really don't know whether there is a change or there is any benefit of those things. So that's the reason it has not completely come as a regulatory guideline for neonatal resuscitation. Now, what are the gaps in our knowledge? And this is very interesting. As I said earlier, we do not know how often people should get trained, so that we don't forget what we have been trained about. We do not know the effects of briefing or debriefing on team performance. During and just after delivery, cord management techniques for various populations, such as non-vigorous infants or those with congenital heart or lung disease. So these are smaller populations where we do not know what to do there. And optimal management of non-vigorous infants with MSF. So we have got few RCTs, but there are some papers which are saying, which are kind of before and after studies, which have said that there is not much change that has happened. So this probably requires even more studies. Hypothermia, how to manage therapeutic hypothermia. In early resuscitation, what are the most effective devices and interfaces for providing PPV. So we did a study on using a foot-operated resuscitator in human infants versus bag and mask ventilation, and we found that the foot-operated resuscitator is slightly better. It's not yet published, but hopefully it should get published soon. Impact of routine use of ECG during neonatal resuscitation, whether it is going to improve outcomes, we do not know, and whether newer techniques or other devices to measure heart rate can be utilized in neonatal care. Again, optimal oxygen management during and after resuscitation, novel techniques for effective delivery of CPR, such as chest compressions accompanied by sustained inflection. So these are all things which require research to be done and maybe change in the future. Optimal timing, dosing, dose interval, and delivery routes of epinephrine. So these are about various medications. Whatever we use currently is again based on what we know, and we have no way to know whether it is more evidence based or not. Again, indications for volume expansion, etc., and the management of pulseless electrical activity. So these gaps in our knowledge are basically an invitation for people to do studies and find out more answers in these areas. So management of preterm newborn during and after resuscitation, more details we need to have. Management of congenital anomalies of heart and lungs. Resuscitation of newborns in the neonatal unit after the newly born period. So while we continue to apply these resuscitation guidelines for babies in even after a week, after 10 days or so, there are actually no studies that have been done on how to go about doing neonatal resuscitation in babies who need resuscitation after the delivery period. Now, one of the interesting things is we all know that we use saturation monitor and how it has to be applied to the hand. If you look at this background of the saturation monitor usage and how it needs to be applied to the hand, it was done in the NICU and not newly born infant. So you can't really, a newly born infant has a different physiology from a baby maybe who has 3 or 4 weeks in the NICU. So they have slightly different physiology, because one is a transitioning physiology while the other one is a more stable physiology. So it might be difficult to apply everything the same in other areas though we continue to apply it. Okay, so we have discussed this surfactant and so on and so forth, therapeutic hypothermia. We will not go into this, and so this all needs to be kind of researched. So in summary, there has been a lot of progress since 1992, and there has been not much change since the last edition. There are quite a few questions that remain to be solved, and if you're interested in solving those questions, one of the better ways to do it is to go to ILCOR website. ILCOR has a website where it puts up questions that are going to be discussed in the next edition. So I would like to thank everyone for listening to me, and I would probably now go to the chat and see if there are any questions for me, and I will answer if anyone has asked any questions. Okay, Dr. Nani Vadekar has said the first guideline should be to mute yourself in a Zoom meeting if you're not talking. Anyway, so I don't see any questions as yet, and so if there are any more questions, I am okay to answer. And if I don't have the answers, I'll ask some of the people in the audience to answer them.
Yeah. So, Dr. Akash Bang has actually commented that it was very nice and concise presentation, and he's saying that tell in specific bullets what had changed in 2020.
So as I mentioned, there was more reaffirming of what do you say presentation. Many of the evidence got reworked. One of the things that changed was actually the evidence with respect to duration of resuscitation. Fairly it was just 10 minutes, then it became 20 minutes. The small changes such as oxygenation, like 10 to 21 to 30 seconds which change. So those few things have changed, but not many of the things has got reaffirmed, and that has been the major change per se. Okay, so if you give me a minute.
There's one more question, sir. There's one more question, sir. Somashekar, sir.
Yeah.
There's one more question from Dr. Rahul from Aurangabad. Please tell about intact cord resuscitation, something like he's asking.
Yeah, so yeah, I actually wanted to speak about it, but I did not discuss it. I forgot about it. So intact cord resuscitation is something which is new, which has not come. I was expecting it to come, but it has not come. It is quite a heavily researched topic. There's a study that has been done in Chennai, and which I don't know whether it's published, but it was presented in Neocon in 2018, where after the baby is born, the cord is not cut, even if the baby is not breathing, and the baby is placed next to the mother on a specific trolley. There are names for it, like Life Start trolley or something in the UK, and there have been publications with respect to this. And the baby gets resuscitated next to the mother, while the cord is still intact. Okay, so that's how kind of it is. That's so I will maybe share a few slides.
Yes.
So okay, so one of the things that got covered, what was looked at in 2020, a lot of topics were looked at. So one was prediction of the need for respiratory support in the delivery room. So there was no very confirmed answers from that review, so nothing changed. Again, effect of briefing, debriefing following neonatal resuscitation. So while it was looked at, nothing changed because not much change was noticed. Okay, for warming adjuncts, what was looked at in resuscitation. So they kind of confirmed what was there previously. For suctioning of clear fluid, they have made a more clear-cut recommendation that for normal babies, you don't need to suction the mouth for all babies who are normal. Pele it was a suggestion. Now it has kind of become confirmed. Okay. For tracheal intubation and suction of non-vigorous meconium stent newborns. So this was again studied for the 2020 recommendation because it was changed in the 2015 recommendation. And again, they found that they did not have to change it much, but they had more published data to say that you don't need to suction non-vigorous meconium stent newborns. They again looked at heart rate monitoring during neonatal resuscitation. So again, the change was that we continue to use ECG and try and rely on ECG. They looked at sustained inflation because that was supposed to be one major change which did not happen in 2015. And if you look at the NLS of UK, where they utilize sustained inflation during deliveries, ILCOR had not recommended, but NLS in UK, I think, were using sustained inflation. So the ILCOR looked at it, and the AHA in this particular guideline also did not recommend sustained inflation. So though it was looked at, because there was no change, they did not use it. Then there were studies looking at PEEP versus no PEEP during resuscitation. That did not change much. So the point what I'm trying to say, I'm talking about all the questions that they looked at during this, and since there was not much change when they found out, they did not suggest anything. So they looked at T-piece resuscitator versus self-inflating bag for ventilation. So that change also did not happen because they did not have enough data. They looked at oxygen for preterm resuscitation and term resuscitation. That didn't change. They also looked at various CPR ratios for neonatal resuscitation. Again, they did not have much data to change. So again, it did not change. For two thumb versus two finger compressions, they again found more data for two thumb, which was again there in 2015. So they found more evidence for it and they utilized it. For epinephrine or intraosseous or volume infusion, so these are the things that they looked at, and they didn't find much change. They also looked at whether soda backup is useful. Okay, and of course they did not find it useful, and so we don't find it changing from 2015 to 2020. For rewarming of hypothermic newborns, nothing much has changed, and so the point I would want to say is that while they looked at all the topics, not much really changed, and so that's one way of looking at it. So and if you look at the way the paper is published, it looks at changes which happened, and they immediately in the subsequent, in that next paragraph itself, they have references which show that on what basis they're making those statements.
Okay. So, sir,
Okay, so
few more questions, sir. Dr. Manish was asking, like, nasogastric tube should we put for every baby?
no, that's not there. It's not part of any.
Yeah. Then Dr.
Not part of
Akash
any.
is again asking, does AP and WHO has separate oximetry target for preterm infants?
I don't know. As far as I know, I don't think there are any separate what do you say, graphs or guide or targets for preterm babies. There are studies that are there, but I don't think there is any particular target for preterm babies as yet. We generally use the term babies target, but we know that it is not the correct one. So with that knowledge, we should be using the term baby targets.
Dr. Rohit is asking, if baby doesn't cry immediately after birth, first heart rate after birth is checked at birth or at 30 seconds according to NRP?
So this is a good question. So baby does not cry at birth. So what happens is, as of now, if the baby does not cry at birth, then you cut the cord and take the baby to what do you say, to the warmer and do your initial steps. So at the end of initial steps, you're going to be checking. So one of the things that we need to always ask when we do these questions is, when the guidelines are made for a team. But when we are resuscitating, most of us are resuscitating alone. So when the guidelines are made and when people work as a team, we know that when you are residents and 2 or 3 people go, then one of them will be always auscultating the heart rate of the baby when the baby is taken to the warmer. So usually you have an idea of what the heart rate is. Definitely you have an idea whether the heart is there or not. Okay, but when you're resuscitating alone, then it is a difficult task. So there, the suggestion is to go and do the initial steps, and once you finish the initial steps, then check for heart rate and respiration. So if you look at the, if you look at the, what do you say, guideline itself, in the algorithm, it is very clear as to when you're going to be checking the heart rate. Okay, so that's the best way to check what is there. So if you look at birth, what do you say? If the baby is neither term gestation or good or not breathing or crying, then you do the initial steps, which is warm and normal temperature, then position, etc. And then at that point of time, you check whether apnea or gasping or heart rate below 100. So at the end of initial steps, you should be checking whether heart rate is 100. So that's for when you want to go. So it's after maybe 30 seconds. If that answers the question.
Yeah. So this is one interesting question. If heart rate is rising with positive pressure ventilation, but the respiratory efforts are poor, then till what time should we continue PPV or should we intubate?
Okay, so I don't think there is a particular answer at what time you should do it. So one of the things is, if the baby has not been breathing and you started doing bag and mask ventilation and you found that the heart rate increased and remained steady at 120 or 130 or 140, but the baby is not breathing, and it can happen in various scenarios. So what you would want to do is you would want to continue giving bag and mask. One, if the baby is like a bigger baby, mother was given GA or some anesthetic and you expect it is some drug, then you might wait for some time before you intubate. But if you know that there was some problem, there was a prolonged labor, there's likely to be chances of severe birth asphyxia because there was prolonged labor, etc. And you know that the baby may not start breathing now immediately. So this is based on what risk factors were there. Then it might be a better step to just intubate the baby and shift the baby to the NICU. So depending upon the setting, you would take a decision rather than just following a particular guideline. So it's always important to understand what kind of clinical setting is there and respond to the clinical setting rather than take a decision just based upon like 5 minutes or 10 minutes or 15 minutes.
Okay. I think that's all, sir, from here. No more questions. And
so I will share. I will share something. What is it? So what Akash asked, what I changed, I think in the first few slides, I had showed about reaffirming the guidelines. So all the major changes which are there are were those in the first few slides itself. Okay, so now I will, because somebody asked about I will just quickly run through a few slides. I hope there is time. And what I'm talking about is your.
Somshekar, you can share your PPT as
Yes,
a
screen.
PDF. We will circulate it with everyone. I
Yeah.
had one question. When you start
Yeah.
giving oxygen and TP's resuscitation in babies less than 30 weeks or 28 weeks, how do you manage the blender? Do you have a blender, or because it's for all the practitioners that we all know 100% oxygen is not good, and getting a blender, and how do you manage to give delivery room CPAP and transfer these babies to the NICU?
So we have had a blender since 2010 in our delivery room. So the idea is to use a blender. The point is use a TPs, use a blender, and use targets for term babies. But we know that the
So which
targets for
blender
term
you have
babies are not.
got? Which blender? Because all the members would like to know.
I don't remember. I think in 2010 or 11 we had bought it for 80,000-90,000. It was pretty. That was the cost at that point of time. And I remember we bought it through when we bought the CPAP machines, the same dealer. I won't remember the name of the company. Almost 10 years since we bought two blenders, one for the NICU, so where we can move. So for the cesarean delivery as well as for labor room. So blenders, I think, should be bought, and I don't think they're very expensive as of now. The cost has not changed. So I can just share this thing because somebody asked resuscitation for. This I had taken in Varanasi, so I will just not go into the details, but I can just show you. So this is the physiology which changes if the cord is intact. I will just show you the beds. There are very good articles on this. I'll skip this. Yeah, so this is what is called as a live start trolley, probably. Okay, so baby is kept. Yeah, so this is the delivery area. Mother is here, and this is your trolley here. So this is your TPs, and the baby is resuscitated while the cord is not cut. Okay, so these are articles which are published. I will not go into details, but I think I'll show you a picture. Maybe it's gone. So there are good reviews of this. And if you go to Frontiers in Pediatrics Journal, there are good reviews. Yeah, so this is how it looks like. The cord is intact, and the baby is getting resuscitated there itself. Okay, so this is supposed to be the US setup at the foot end, and this is supposed to be the UK setup by the side. There's one done by Chennai. So there's Dr. Mangala Bharti, professor of neonatology from Chennai, has devised a trolley for India, and he has done a study on this. I don't think it is yet published, but it has, I think, 120 or 130 babies in it. And mothers who got this intact cord resuscitation were quite happy. Okay, so that's that. I just wanted to show what is meant by that. Yeah, I think that's it from my side. If there are any more questions that I missed.
Yeah, excellent presentation.
Thank you.
Shekhar. Excellent.
Yes.
I'm sure everybody goes home with a lot of refreshed knowledge and motivation. I would like to also thank all the delegates and ask them to give some suggestions if for the topics that they would like to listen, which may be interesting. Your suggestions are most welcome, because finally at the end of the day, the topic should be of relevance and interest to you all. That's why I think this is something which would really help us design and ask the best of the best faculty to speak on those topics. So please share your views and kindly let us know as to what are the topics which would be of relevance to you and me in day-to-day practice in days to come. And secondly, I would also like to thank Ghansham, who has helped us do this webinar in a much better way. Over to you, Sunil. And members, please become members of the state NNF chapter. I think that's very important. I request all of you to kindly contact Sunil Gawane to become the member of the state
Yes.
chapter of NNF, we need to become a bigger family.
Yeah, this again sincere request. I'll reaffirm or reiterate again, like NRP. Please, please do become a life member of state chapter. Immediately responded to your sir like appeal. Dr. Nandakishore has actually said that updating BPD. So we'll request everyone to come up with such a topics, interesting practical topics of interest. You are in a day-to-day practice or NIC practice, which will improve your like protocols or management of the babies. So definitely we'll come out next week. We will have one more interesting practical talk. And thank you everyone again for the interactive session. Thank you, sir, for such excellent. Already compliments are there. It's very excellent, and people have requested to share the PDF again, PowerPoint slides with them.
I will share the PowerPoint. I will email it. I will WhatsApp it to you.
Yeah, okay, sir. I'll share it then. Thank you everyone, and
Thank you
again,
and Happy New Year, everyone.
Yeah, Happy New Year. We'll meet again next week, Saturday, same time. Thank you.
Thank you.
Thank you very much. Yeah, bye.